Hey guys, it's Colin. I know we were going to have our first meeting today before class, but snow got in our way. So to not get us behind, I figured I'd just give you the kind of the first 10 or 15 minutes of what we would have talked about today, and then also kind of give you guys a little heads up for Saturday and what we're going to be talking about with Epi in class. So one of the big things that we like to push when we're studying and practicing for our midterms and our finals and doing scenarios is what we call the box system. So I remember being in class a couple weeks down the road from where you guys are at right now, and I remember being really, really overwhelmed with scenarios and not knowing how to organize and what I should do. And every time I would go do a scenario, it was a totally different algorithm. And so, one time I'd do, 7 of the 10 things right. And then the next time I'd go, I'd get 7 of the 10 things right. But of the 7, they were different than, there was different ones in the list. So I sat down and I said, okay, I'm completely confused and like I'm going to fail. And so how do I organize this so that I do the same thing every time, give myself a chance to pass? And so what I did is I took the NREMT sheet or the state DOH sheet, and I looked at it and said, okay, here's all the things that I need to do. And then I broke them down into what I called boxes. And so I said, okay, in box 1, I'm going to do these 4 things. And until I do these 4 things, I can't move on to anything that's in box 2. So I kind of regimented it. The way I like to think about it is baseball, right? Like we have to run to first base before we run to second, before we run third, before we run home. And so what the box system makes you do is it makes you hit every base on the way there. So what I want to do is just do what we would have done today, and that is just go through the box system. Most of this should be pretty similar to the stuff we introduced to you guys the last 2 Saturdays. But I want to get it down on paper here. I'd highly suggest taking notes to it. And then when we practice outside of class on Mondays and Wednesdays, we're going to hold you guys to this system for a very particular reason, and that is we know it works. So if you do everything from box 1 through box 4 in order, you will pass your midterm, you'll pass your final, and you'll have your National Registry cert. So we know it works. We've been using it for a couple years now. And the nice thing is everyone who's going to help instruct has used the box system themselves as a student and now teaches it. So you're going to have a lot of experience with it, and a lot of people who can say, yeah, this is the way to tackle kind of the overwhelming task that it is to run a major medical scenario or a major trauma scenario. And down the road, when you get to trauma in the back half of the quarter, the box system is really great because you've built in all these good habits and a good algorithm that's going to transfer really well to trauma. Because trauma has a few different things, but if you use the box system, then you're only substituting a few pieces out from medical, and then you put in the trauma aspect of it. So you're building yourself a really good muscle memory from the beginning. So with that said, let's kick into it. So the box 1 is going to be the first 4 things you're going to do. So we introduced this to you guys last week. So it's BSI, scene safe, number of patients, and your general impression. So if you weren't in Matt and I's group, then maybe this will be a little bit different to you. But when we give you the dispatch and you walk through the door, the first thing we want you to do is walk in, close the door, and stop. And don't move. And don't move until you've done all these 4 things in box 1. So you're going to say BSI, so you're just telling us that you have your gloves and your glasses on. If there's any other need for any other kind of PPE, like we'll tell you ahead of time, but 99% of the time it's just going to be gloves and your glasses. So BSI, then you're going to ask the question, is my scene safe? To which we're always going to respond yes. If for some reason someone said no, then you would just turn around and walk out the room. So that doesn't really do, right? It doesn't really do anything beneficial. So the answer should always be yes. Okay. Then you're going to ask your number of patients. Your number of patients should be 1. I can't think of a time where you're going to get more than 1, and especially on your midterm and your final practical for the NREMT, you will only have 1. So you can guarantee yourself that the answer is going to be 1. And then you're going to ask the question, what is my general impression? So there's been a little back and forth about this over the last year or so, about whether you're supposed to walk in the room and say what you see, or whether you're supposed to ask what you see. And so if you look at the scenario-based learning guideline that Matt put together, it very clearly states that you're going to ask what your general impression is. So again, from the top, I'm going to walk in, close the door, stand still. BSI, is my scene safe? Proctor says yes. You ask, well, my number of patients. Proctor says you have 1 patient. And then you'll say, what is my general impression? And then for this one, we'll just use a patient that we've been talking about a lot, right? So your 62-year-old male with a chief complaint of chest pain. No judgment on my writing, okay? I made that worse. So the general impression for this patient is going to be something akin to, you have a 62-year-old male seated upright in his living room chair. He notices you as you walk in, and you can tell that he's kind of uncomfortable and he's holding his chest. Excellent. Now you can approach the patient, and that will cap off box 1. I'm going to try to keep this all on the same screen here, see if I can zoom out a little bit. Excellent. So box 2. Box 2, you're going to approach the patient. You're going to take a knee. So this is something that we see often in the first week or so of scenarios, is we're not used to real life walking up, shaking someone's hand and like taking a knee, right? That's kind of odd. But in EMS and in the fire service, that's what we're going to do. We're always going to get down to their level or below them. So we never want to be standing above our patients. So we're going to come up, we're going to take a knee, we're going to offer to shake their hand. If they don't, reciprocate with shaking their hand, then we're going to feel for their radial pulse. But if we can shake their hand and grab the radial pulse, that's the idea. So we're going to walk up, we're going to introduce ourselves. And that's going to be something to the effect of, hi, my name's Colin, I'm with the fire department, what's going on today? You can have any variation of that you want, hi, I'm Colin with the ambulance, or, on and on, you get it, right? But have a set intro that you say. So I'm going to introduce myself while I'm grabbing the radial pulse. And the patient's going to say something back to me because I asked him, what's going on today? Or why did you call 911? And so then I'm going to get from them their chief complaint. So our 62-year-old male is going to tell me, my chest really hurts. I'm having some chest pain. Okay, perfect. Because he answered my question, right, and I'm looking right at him, and I felt his radial pulse, you can verify the ABCs. Okay, so the way we do that is you say out loud, my patient is alert and has a patent airway because he's talking to me. He's breathing at a normal rate, and he has a strong and regular pulse. Now you know that he's breathing at a normal rate because you're staring right at him, right? He's right in front of you. And you know he has a strong regular pulse because when you introduce yourself, you went and grabbed it, right? And you're feeling it. So if one of your fellow students is playing the patient and they're really hamming it up, right? And so they're breathing 30 plus times a minute, then you can say, my patient is alert. They have a patent airway because they're talking to me. They're breathing at a rapid rate, and they have a strong and regular radial pulse. Okay. So just, don't make stuff up. Say what's sitting right in front of you. But then you're going to say at the end of that, tie it all together, you're going to say, so my ABCs are intact. This is a major fail that a lot of people miss. So verify your ABCs. The next thing you're going to do is you're going to upgrade to ALS. And you're going to upgrade to ALS based on that chief complaint. Right? So when I introduced myself, said, hi, my name's Colin with the fire department, what's going on today? Then the patient said, oh, my chest isn't feeling good, I have some chest pain. After I verify the ABCs, I can upgrade to ALS based on the chief complaint of chest pain. So chest pain is an ALS indicator. Same thing with difficulty breathing or shortness of breath. These are ALS indicators. And so you have 60 seconds from the time the patient tells you the ALS indicator for you to upgrade. Otherwise, the scenario's failed. So don't waste any time. They already told you that that their chief complaint is an ALS level complaint. So go ahead and upgrade to ALS. Last thing you're going to do in box 2 is you're going to assign O2 and vitals. And so you're going to turn to your partner and say, can you get me 15 liters per minute of O2 via non-rebreather and get me a full set of vitals? So not so much in class, but certainly when you're practicing with us, we're going to be very particular about that. So not just can you get me some oxygen and can you get some vitals, right? We want you to say exactly how much and on what device, and then also a full set. If you don't say a full set and your partner goes and takes a blood pressure and stops, which happened, by the way, in one of the groups on Saturday, the partner just took a blood pressure. And so they're like, what are the vitals? And they only had a pressure when we're missing a lot of information, right? So we're going to be big on you guys spelling that all out. So that's the end of box 2. We'll take a second here and pause. So box 1 and box 2 is where everybody fails. So a month from now, nobody is making the mistake of giving the wrong drugs or missing contraindications or the drug dosages or doing doctor temp, kind of the stuff that seems hard right now because it's so new to you guys. But that'll get hammered in. You'll have that down, no problem. What you'll forget is the ABCs. You'll forget ALS. You'll forget to assign vitals. You'll just say O2. And we see this every single quarter. It's the same problems over and over and over again. So we want to hammer box 1 and box 2. And we call these the non-negotiables. So these are the things that you have to do every single call, no matter what the problem is. So if you're going to go to a 19-year-old female with abdominal pain, the first things you're going to do are box 1 and 2. If you go to a 62-year-old male with chest pain, you're going to do boxes 1 and 2. If you go to a trauma and the guy has both of his legs cut off below the knees, you're going to do boxes 1 and 2. Okay? Because the failure, if you miss any of those, it's an automatic fail. So box 1 and 2 are going to be incredibly important, and we're going to harp on that a lot over the rest of the quarter. So moving on to box 3. So box 3 is going to be your OPQRST, sample, and then you're going to listen to lung sounds. So pretty straightforward, right? This is just your history taking. So you're going to ask them OPQRST and sample just like we taught you guys. And then for this 62-year-old male with chest pain, we're going to go ahead and listen to his lung sounds at the end of asking questions. Not to get you too confused, but as we get into epi and MDI, so respiratory issues, people who have an anaphylaxis or an asthma attack, or if we get far enough down the road, things like COPD or CHF, we're going to move the lung sounds from the bottom up to the top. So just going to depend on the scenario. But for now, just think about it in this order. You can do the lung sounds at the end. If for some reason you want to do lung sounds before you launch into OPQRST and sample, that's not the end of the world. Just make sure you do that every single time. So if you're not doing the same things in order every time, you're going to have a hard time building an algorithm. You're going to have a hard time doing that first base, second base, third base thing that we were talking about earlier. So once you get through that, at the end of box 3, you should have the story, right? And the story came from here, from your OPQRST and sample. And then from over here, right, your partner should have the vitals done. And so the whole job is about two things. It's about a story and a set of vitals. You're going to put those two together and make a decision about what to do. So when we give you the 62-year-old male with chest pain and you've heard it 10, 15, 20 times, you already know right away at the start of box 2, I'm going to give, aspirin and nitro. And so when you get done asking all the questions and listening to lung sounds, right, you go, I'm going to give aspirin and nitro, but you don't even know what the vitals are yet. Now, for the purposes of playing a game, that's totally fine, right? Because you know this is a scenario, and I know where this is headed, but it's bad habit to build into you because in real life, right, the story is only half of what we need before we decide what intervention we're going to give. So we need a story and a set of vitals. So make sure that before you move on to box 4, you have the vitals from your partner so you can make an informed decision about what you're going to do. So in box 4, this is where we're going to start making decisions about treating the patient. So the first thing we're going to do is we're going to choose what medications we're going to give. So for our 62-year-old male with chest pain, after we get done with the story and a set of vitals, it turns out that, I think that this guy's having a heart attack. So I'm going to give aspirin and nitro. So then what I'm going to do is I'm going to do Dr. Temp, and I'm going to do Dr. Temp, and I'm going to do contraindications. And here's my 2 cents on this, and I think that the rest of the instructors are on board with this as well. Don't make the mistake of doing Dr. Temp for both medications and then doing contraindications for both medications. Do one medication in its entirety and then go to the next one. So take up your aspirin and say, I'm going to do Dr. Temp for aspirin, and then run down Dr. Temp for aspirin. And then do the contraindications for aspirin. Take aspirin, set it on the ground, pick up the nitro, do Dr. Temp for nitro, do contraindications for nitro. What we see all the time is someone picks up the aspirin, they do Dr. Temp for the aspirin, they do contraindications for the aspirin, they pick up the nitro, they do Dr. Temp for the aspirin, then they do Dr. Temp for the nitro, then they'll do contraindications for the nitro, and then they'll give the med, and they'll have never done contraindications for the aspirin. So if you just knock out one drug in its entirety and go to the next one, you're eliminating the chance of missing something. Again, if you want to do Dr. Temp for both meds and then you want to do contraindications for both meds, that's fine, but the expectation then is that you personally are going to do that every single time. And so if one of the instructors catches you going back and forth in the scenarios, then we'll kindly suggest that you pick a side, right? Because the more variability you have in how you go through this, the higher chance you have to fail when you're nervous and you're on your test day. And there's no need for that because I think that we've figured out the easy way to do it from our own trial and error. So, learn our lessons, right? Make it easy. So we've chose our meds. We got Dr. Temp. We got our contraindications. Then the next thing we're going to do is call the doc. And because we got some time here, I want to talk about how we're going to do that. So the phone call to the doctor should be very simple. You don't have to recount all of OPQRST and sample and all of the vital signs. And it's not necessary. So the call is going to go a little something like this. So ring, ring, right? Hey doc, this is Colin on Medic 111, calling for permission to give 324 milligrams of aspirin and 0.4 milligrams of nitro up to 3 times for a 62-year-old male who I believe is having a heart attack. His vital signs are blood pressure 170/92, his heart rate's 120, he's breathing 20 times a minute, and he's diaphoretic. Do you have any questions for me? So at that point, if the doc wants to know Q or R or their past medical history, then, she'll ask you, right? And then you'll answer her and tell her, okay, this is what, he's had 2 heart attacks in the past. But if you present it in a very concise and clear way like you did, then the chances of them asking questions are less, right? It comes off as a more confident EMT. Notice when I was talking and giving that short, like I wasn't speaking really fast, right? I kind of spoke like in a very static, easy, calm manner, because there's nothing about the short report that needs to be rushed, right? We want to make sure that we get across what we have in front of us to the doc. The big takeaways are you want to say who you are and what you're calling for right away. So my name's Colin on Medic 111, and I'm asking for permission to give, whatever the drugs are I want to give. And then why? Because I have a 62-year-old male who I think is having a heart attack. And then I back that up with the vitals. And then I ask, hey, if any questions, more than happy to answer them. That is a good, short call to the doctor. It doesn't need to be anything more in depth than that. You just need to be ready to be able to answer any question the doc would ask. So if they say, what medications are they on, you need to be able to repeat back to the doc what M from sample was. Or if they say, how long has this been going on for the patient, you need to be able to recite T from OPQRST. So that'll be the end of box 4. Okay. At the end of box 4, we have everything we need to give the medications, right? So box 5 is all about giving the medications and getting the heck out of the scenario so we can pass and move on. So once I call the doc, then I'm going to administer the meds to the patient. So in this example, I'm going to give the patient 324 milligrams of aspirin, tell him to chew it up. Then I'm going to have him lift his tongue. I'm going to spray it under his tongue, and there we go. I've got my first dose of nitro on board. Now the test is over at this point, right? You've done everything you need to do up to giving the med to the patient, and you just gave it to him. And now we want to get out. We want to end the scenario. We don't want to give the proctor a chance to mess with us and fail us. So we're going to vomit out this exact same thing every time, whether we gave aspirin, nitro, or if we gave meter dose inhaler, or if we gave epi. This is going to be the same ending. Box 5 is the same every time. You're going to say, I'm going to reassess the patient in 3 to 5 minutes. Okay? You're going to ask, how far is ALS / the hospital? The proctor is going to tell you how far ALS is and how far the hospital is. If ALS is 5 minutes away and the hospital is 20, then you're going to wait for ALS. Pretty simple. If ALS is 20 minutes away and the hospital is 5 minutes away, then you're going to take the patient to the hospital. Right? The end goal is to get them to a higher level of care as quickly as we can. So make your choice, right? So that seems pretty simple. If they say something like ALS is 10 minutes away and the hospital is 10 minutes away, well, there's no real good, easy way to make that decision. Make a choice and be able to defend it. Okay? So when I hear that, my thought is, well, it's going to be 10 minutes till ALS gets here. Then they're going to do all their work, and then they have to drive 10 minutes from where we are to the hospital. So that sounds to me like it's going to be longer if I wait for ALS than if I just took the patient to the hospital. They'll get a higher level of care more quickly. Okay, fair enough. Someone could argue differently, and that's fine, right? But I just justified my decision. So you need to do that same thing. Make a choice, justify your decision. You don't have to do that, though, if the times are so different, right? Like one's 5 and one's 20. Easy enough. Okay? And then you're going to finish every scenario by saying that there's nothing else you want to do for this patient. Okay? When you say that, the timer stops, and you get 10 minutes to do these scenarios in your midterm and on your final. So the other good thing is the only thing that the proctor is allowed to ask you on your National Registry final and we'll start doing this too on the weekends, is they're gonna, when you're, when you think you're done with the scenario, right? So when you tell me, I'm gonna reassess in 3 to 5 minutes, how far is ALS, how far is the hospital? Okay, I'm gonna go ahead and wait for ALS. And then you sit there and don't say anything. The only thing the proctor is allowed to do is to ask you, is there anything else you'd like to do for this patient? And then you'll sit there and you'll start getting nervous and your eyes will get big and you're like, oh crap, what did I forget? And then they're going to say the same thing to you. Is there anything else you want to do for this patient? And now you're tripping, right? Because you thought you nailed it, but why is this guy asking me if there's anything else I want to do? And that's because it's the only thing that they're allowed to ask. They're not allowed to suggest or say, okay, you're done, right? They can only ask, is there anything else you want to do for this patient? So you cut them off and you avoid all that awkwardness by you just saying, there's nothing else I want to do. So let's recap box 5 real quick. I'm going to give the medication, and as soon as I do that, then I'm going to say, I'm going to reassess the patient in 3 to 5 minutes. How far is ALS? ALS is 5 minutes away. How far is the hospital? Hospital is 15 minutes away. Okay, I'm going to go ahead and wait for ALS, and there's nothing else I want to do for this patient. Done. That is the end of the scenario. As long as you did everything from box 1 through box 5, then you pass. Guaranteed. If you look at your DOH or your NREMT sheet, you're going to notice that there's a few things on those sheets that is not in here. If you want to add them in, feel free. The things that are on those sheets that are not in here are not critical fails. They're things that you can not do or say and still pass. So this is the most simple system that does everything you need to pass and gets rid of some of the superfluous stuff that, in many ways is unnecessary. None of your proctors are going to knock you for it. And if they do, they're kind of on an island. You're going to notice that it's like one person's thing, right? And everyone else is okay with it. I can promise you, because we've done this now for a few years, and like I said at the beginning of the video, this was the system that got me through. If you do everything from box 1 through box 5 in order, you'll pass. Overall, like I've said to you guys before, this is all pretty simple stuff. It's just a lot of stuff, and a lot of it really quickly. And I think the box system really helps organize what you need to do. And the goal is to be able to look at you and say, hey, box 2, because you're about to go to box 3 and you've missed something in 2. And you know, oh yeah, I know what box 2 is, and you run through the list and go, that's right, I'd like to upgrade to ALS because of chest pain. And there you go, you caught yourself, right? So that's the box system. I hope it helps. I hope this organizes your thought process when you're doing scenarios. And when you practice with us, this is going to be the template that we use. And if you have any questions about it at all, that's what the Mondays and Wednesdays are for, is for us to work out the kinks with this. And then hopefully, by using the system, you guys start running through these scenarios really quickly. We can start talking about some of the cool stuff that we don't get to on Saturdays, like seizures and strokes, diabetic emergencies, cardiac arrests, a bunch of stuff that we see a lot of, but that we don't get to talk about because we're so limited in time, right? 1 8-hour study session is barely enough to get through what we need to get through to you guys. So yeah, hope this was helpful, and I will see you guys at the end of the week.